The content herein is for informational purposes only, not intended as medical advice, diagnosis, or treatment, and is not to be substituted for direct advice from your doctor.
Welcome to LymphCast, the gathering place for physicians, healthcare experts, and special guests. We dive into the world of lymphedema, venous disease, and other related disorders, exploring their impact on your daily life. So settle in, unwind, and join us as we uncover everything you need to know about lymphedema and related conditions on our engaging show LymphCast.
Today's LymphCast program is proudly sponsored by VitaSupport MD, the makers of Vein Formula 1000 and Lymphatic Formula 1000. These MPFF-based nutraceuticals are backed by science and recommended by doctors specializing in venous and lymphatic disorders. Visit VitaSupportMD.com to learn more.
Greetings and welcome to our LymphCast show, episode 29 tonight. We have a special guest with us and also most of our regular panel. So let's go around the room and meet everybody. From Arizona, Dr. Monica Gloviczki. Greetings, Dr. Gloviczki. How are you?
Hello, everybody. Nice to be with our super team and welcome today a guest of this podcast, Brian Tuckey.
All right,
I hope that I pronounced correctly. Right?
It's a Tuckey.
Tuckey. Okay, wonderful.
All right, very good. From New York, make sure I get the right state this time. Jacqueline Sasek. Greetings, Jacqueline. How are you?
Good, Paul. Thank you. Happy to be here again.
All right, nice to have you with us. From California, Dr. Emily Iker. Hello, Dr. Iker. How are you?
How is my wonderful team? Hi, everybody. I'm so glad to be back from cold, windy London. And it is so great to learn something from our new guest, Brian Tuckey.
All right, very good. From New Jersey, a physician and surgeon, but he's also the founder and owner of VitaSupport MD. They make Vein Formula 1000. They make Lymphatic Formula 1000. As I said, physician, surgeon from New Jersey, Dr. John A. Chuback. Hello, Dr. Chuback. How are you?
Hi, Paul. Thanks very much. I'm doing great. Looking forward to today's show.
All right. Now, before you bring the guest in, Dr. Chuback, if you don't mind, you've been doing something a little special away from this show, and I've been helping you with it, like 1%. You do the other 99, of course. But you've written this book, Blueprint for Your Success Story, and every single day you're putting on the podcast page a 3, 4, 5, 6 minute chapter. Maybe just, if you don't mind, just tell the listeners and viewers about that book.
Yeah, that's one of my passions, as everyone here knows, is personal development and sharing what I've learned in that space. My latest book, I'll hold it up, is Your Blueprint for Success. The foreword was written by Brian Tracy, one of my personal mentors. And it's a book which is really a compendium of words that I think have great power in how we think and how we behave. And so, yes, Paul, we've been doing this podcast, which I think is something new for us. You and I have done podcasts in the past, several of them, but these are just 3 or 4 minute podcasts where we cover one word each and every day. So it's been fun to do, and so far the feedback has been great.
All right, very good. We also want to tell our listeners and viewers it's time to get your questions. If you have questions for the panel anytime, send them in. I'll give you the email address. We'll put it in the show notes as well. It's hello@lymphcastnetwork.com. It's hello@lymphcastnetwork.com. And then on the next show or the show down the road, one or more of the doctors will address that question. So we look forward to your questions. Okay, Dr. Chuback, with that, you want to bring in our special guest? We'll get going.
Yes, I would also want to mention one thing before we introduce our special guest, that everyone should visit Monica Gloviczki's wonderful site where she shares her beautiful fine art, monicagloviczki.com, and also the Lymphedema Center in Santa Monica, California, where Dr. Iker is, because I know many of our patients have been interested in both seeing Dr. Gloviczki's artwork and also knowing how to reach out and find Dr. Iker in Santa Monica at the Lymphedema Center. So both of those websites are wonderful, and I encourage everybody to visit. Switching gears to today's show, I want to first say hello through the airwaves to our friend, Dr. Mark Melin, who could not be with us today, but we owe Mark a great debt of gratitude, as always, for his never-ending energy, enthusiasm for medicine, and curiosity. And I'm going to thank him for bringing to us Brian Tuckey. Brian is really a new person in my life professionally and from a clinical point of view. And Mark is not here to introduce Brian, so I will. My understanding is that Brian is was a protege of Dr. Lawrence Jones, who was an osteopathic physician, and that he is an expert in what is known as strain and counterstrain treatment. And this is a fascial counterstrain technique, and it is able to help with identifying and correcting dysfunction in numerous body systems, including the musculoskeletal system, but apparently also the vascular system and lymphatic and nervous system and others. So I'm very intrigued to learn more about that. This is quite new to me. And apparently the physiological rationale behind this fascial counterstrain is impaired lymphatic drainage, or there was a paper written, which is interesting, impaired lymphatic drainage and interstitial inflammatory stasis in chronic musculoskeletal and idiopathic pain syndromes, exploring a novel mechanism. And this was published by Brian and his colleagues in Frontiers of Musculoskeletal Pain in August of 2021. And my understanding is the number one most viewed article in the journal of all time. I was visiting Brian's website, and I saw a beautiful, beautiful testimonial from the very well-known best-selling author and motivational figure, Tony Robbins, who mentioned this technique in his book, Life Force. How new breakthroughs in precision medicine can transform the quality of your life and those you love. So my understanding is that Dr. Mark Melin, our colleague and very dear friend, became aware of and read Brian's paper, this very well-known and groundbreaking paper, and reached out to Brian, introduced himself, and they made a connection and have formed a bond. And he thought that this information would be very important for us and for our listeners. And so I'm going to leave it there, and I'm going to welcome Brian Tuckey. Welcome, Brian.
Well, thank you for the invitation. I appreciate being here.
It's a pleasure. So do I have that correct? Is that how you and Dr. Melin came to know one another?
Yeah, that's a pretty good synopsis. The only thing I would say I would tweak in that intro was that the technique that is the modern version, which I developed and teach, and Tony experienced and the articles written about, is called fascial counterstrain, and it is the next generation of the classic osteopathic technique that was strain counterstrain. So, in other words, if you talk to an osteopathic professor who's been practicing for 50 years, he'll be aware of strain counterstrain, but maybe not the modern version. And so I was one of Dr. Jones's original 4 certified instructors. And I was, pretty much the youngest one that he had certified. He passed away in '99. And, at that point, we had about 180, 190 different techniques. The diagnostic was simply a tender point palpation. We knew what these particular releases did to the body, but there really wasn't any anatomy associated to the tender points. They were just named regionally. So it was kind of, shotgun manual therapy. You would just take a shot and hope it worked. So over the process of really 33 years now, I've been practicing, I was able to figure out that we were working on the body's deep fascial systems, extensively just followed the research in all areas of pain science, fascial science, neurovascular dysfunction, and, put the paradigm that was published in 2021, which really describes what you're seeing. But now the technique has expanded to really over 1,200 different releases, encompassing every tissue, every fascial tissue in the body, all systems, and both peripheral and central nervous system treatment. So it's kind of like, I always tell the patients, they're like, so how is this different? I said, Dr. Jones made the telephone, but this is the smartphone.
Interesting. So can you begin, for those of us who are new to this, by explaining to us the classic strain counterstrain technique, which is long been understood, and then we can go from there to the smartphone.
Yeah, so Dr. Jones was an osteopathic physician that practiced as a primary care doctor, as most of them did, back in the 50s, 60s. He had a patient come into him who had chronic back pain, had seen 2 or 3 chiropractors for weeks and months, and really made no progress. When he showed up to Dr. Jones, he had what the osteopaths term a psoasitis, which is a contraction of the iliopsoas. He was flexed. He was stuck in chronic pain, couldn't stand erect without pain. And Dr. Jones himself at that point was a high velocity, pop and crack type manipulator, performed 5 weeks of manipulation on this gentleman without relief. And the guy came in and said, I think I could respond if I could just sleep. He's like, I can't find a comfortable position. I'm tossing, I'm turning. How can I heal if I can't sleep? So Dr. Jones agreed, and he said, let's just spend today and try and find a position of comfort for you. So he started experimenting, flexion, extension, side bend, rotation, eventually found a position markedly flexed, legs off about 60 degrees to one side, where the guy said, right there, I don't feel any pain. So Dr. Jones propped him up with pillows and said, let's see if you can, sleep in this position. Can you stay comfortable in this position? Went back, treated several patients, checked in on him a few times, and the guy was, thumbs up, I feel great. And then eventually came back in. He said, okay, apparently you can sleep like this. Pulled out the pillows, had the guy stand up, and he stood up perfectly straight. And they both looked at each other, and he's like, I don't feel that sharp pain. So Dr. Jones said, go ahead and backward bend. And he went into extension, had about 50% of his extension back, whereas he couldn't even stand erect previously. Dr. Jones then went back, reassessed him, and saw that L2 flexed dysfunction that he had felt for months was gone. So, really just observed that positioning could cure dysfunction, or at least treat it short term. Then, several weeks later, he came back for his next session. The guy walked in erect. He said that he was markedly better, wasn't pain-free, but he was so much better. Dr. Jones reassessed that area, saw that segment, stayed improved. And then, at that point, he realized that was some type of permanency to that atraumatic positional treatment. And he started, positional release is another name that it's gotten, the general approach. So he started to experiment with, stuck joints and positions of ease, and realized that he could find a position where the whole vertebra would kind of float and relax. And then if he stayed in that position, there would be this unknown resolution of the problem. It would just disappear. It had way better carryover than anything that he had found. He gradually realized that the surface tension that was produced by these deep areas of restriction could be diagnostic in nature, and called them tender points. And then he started mapping out, for this tender point, we use this position, and here are the symptoms. And ended up with, again, about 180 of these tender points, anterior, posterior parts of the body, even some craniofacial tender points. And that's where I kind of jumped into the treatment. This was around 1990, 91. And I had studied, for 2 or 3 years with various manipulation approaches. Wasn't really happy with my carryover, to be honest. You'd manipulate, and it really wouldn't last. People would need either dozens and dozens of the same treatment, or it would just come back every time. So when I tried Dr. Jones's approach, which had just been recommended to me by a fellow practitioner, I then kind of tested it in the clinic, checked it on my own body, checked it in my demonstration lab partner. And it was the first time I ever saw permanency to manipulation, where you could do it one time and you didn't have to do it again. That particular thing would change permanently. So that's really what had me hooked from the beginning, was just the outcome was just different, and it was painless. To be honest, at that time, we really didn't know what we were doing. It was just find the position, use your hands to find that softening. We documented the positions, at least they were reproducible. And that's where it was when I jumped in. So
let me stop you right there, Brian, if you don't mind, because that's all fascinating, and I'm learning a lot. But it suddenly occurred to me, I think I'm going to ask Dr. Iker, Dr. Emily Iker, maybe to comment. Dr. Iker, you may or may not know, is a physical medicine and rehabilitation doctor. Yep. She had a couple of years of surgical training prior to that, where unfortunately she had an illness that made her surgical career impossible, quite frankly. So I'm wondering, Dr. Iker, as a PM&R specialist, are are these techniques that Brian Tuckey is referring to, are these things that you're aware of as a medical doctor involved in PM&R?
Well, PM&R doesn't give you the benefits of this fantastic treatment, but I am so eagerly listening to you because my son was born with congenital scoliosis, and not knowing what I was doing, I was giving him the same treatment as you are describing. When I took him to the orthopedic doctor, he was borderline, and the suggestion was, well, we can put the rods and it will be corrected. And I thought, no, then his growth will stunt. And because he is now 15 and a half. So since he was born, I was doing the counter manipulation and release of the you can call it fascial release. I was not aware it was tense. I was stretching his muscles and so on. But after about 3 months of the treatment, intensive treatment, guess what? His scoliosis improved significantly. And I'm just dying. We just got back from the trip. So I'm dying to see an x-ray and see the correction, because when I examine him, which I do pretty much on a daily basis, I see that the curvature really improved. So I'm kind of doing what you are doing, not knowing what I'm doing.
This is fascinating. This is fascinating. Okay, so then, Brian, why don't you pick up where...
is so important.
Pick up from where you left off now, Brian. So the story goes forward. Now you got involved with your own addition to this technique.
Yeah, so obviously I want to kind of get through some of the history, and then we'll get into the modern physiology. But the difference between classic manipulation approaches and myofascial release, it's been around for hundreds of years. Counterstrain is an indirect manipulation, and so what that means is we don't engage barriers. We decompress tissues and take them into the position of relaxation. So it's literally opposite the direction almost everyone else is going. Okay. It's kind of like if your sock drawer is stuck and you keep pulling on it, it doesn't work. You shut the door and come back slow, and then it opens again. So it's really in the opposite direction. And it works because we are, and we'll get into your guys' world in lymphatics, we are decompressing and creating an area of decompression and a vacuum, if you will, which is decompressing nociceptors and draining inflammation off of nociceptors. And once you shut down the nociceptive barrage into the dorsal horn, all types of reflexive responses shut down. Muscle guarding, the somatosympathetic reflexes, they all disappear. So in the end, what we saw was that we could feel these areas of surface, and it gets into a concept I'll go into in a second, neurogenic inflammation, okay, or referred sensitivity. We feel the surface, we decompress the source, and you'll feel that entire segment neurologically just shut down. As long as you maintain it long enough to dissipate the fluid, that trapped interstitial inflammation that drives this ongoing problem, it's gone. You pee it out. So it is not something that you're trying to beat the body into submission. You're not working indirectly into it. You are finding the source of that ongoing chemical irritation to that nociceptive loop. You find it, you release it, and it's done. The understanding was, I think the key thing, people look back and say, wow, a lot of people were doing it. What was your mindset that kept you on this journey and made you, follow this down? I was the only one that was saying, what are we doing? I said, if we can't physiologically identify the tissue and identify the physiology behind this, how can it possibly reach its potential? Okay. Yeah, we can all do it. We can all feel it. And I know the science right now doesn't fully explain this, but we have to someday figure out how this works if we want to see where its true potential is. So that was kind of where I never gave up on the science side of it. And everyone else was just kind of practicing and, helping patients. The next big breakthrough, I would say, came from, I had a patient who had pain in the area of the 12th rib, L1, chronic tension in that quadratus lumborum area. And I did everything I could do to help her, went to some of my old techniques. Everyone in town has seen her. No one could help her. And I sent her to one of my mentors who had some osteopathic training that I didn't have. And I said, look, go see this guy. I'm added tricks. Your MRI is negative, but I feel something right in that area. I just don't know what it is. See if Tom can help you. If he does, please come back and tell me what he did, because clearly this is something I don't know. Several weeks later, she came back and said, thank you for the referral. Tom fixed me in 2 visits. And I said, what was it? She goes, it's really kind of weird, but it was my kidney. And so I thought about the anatomy of where I was working, and I was like, that was in the region of the renal fascia. It was in the kidney. So then I started studying with some of the French osteopaths, Jean-Pierre Barral, some of the guys who were doing visceral ligament manipulation, came back from those classes, started looking at my patients at a different way now, with a kind of a visceral fascial organ paradigm, saw layers of dysfunction and new tender points that were not previously described. The techniques they were doing really didn't work that well because they were trying to stretch it. And I applied the counterstrain, position of ease philosophy to all these visceral tissues, like the pleura and the renal fascia, and the ileocecal ligaments of the colon, and it worked. I was able to unlock that visceral tissue the same way we were able to do these other points. And I mapped out about 60 over several years. I actually that first system took me almost 7 years. I mapped out about 60 visceral tender points, went back to the people who were learning the Jones work and said, I've got 60 visceral ones. And that was the first class that I personally held. But that started me down this concept of system-specific tender points. So then I started looking at Jones's work, and I said, wow, this point that we called, the anterior T5, that is this structure. And I started realizing some were lymphatics, some were artery pathways, some were neural fascial pathways, some were muscle tissue. And I have, long story short, realized as I studied more and more about fascia, histologically, it's the same tissue. It's all contractile. Almost all the soft tissues of our body are made of it. It's the external wall of every vessel, including lymphatics, the tunica externa or adventitia. It has neural connections into the spinal cord. It can become inflamed. It's pain generating. So when people say myofascial pain, it's really, that's one subset of pain. It's fascial pain. They all have the same receptors, whether it's visceral fascial pain, whether it's ligamentous fascial pain, whether it's fibrocartilage, whether it's vascular pain, whether it's neural fascia, it's all histologically the same tissue. And it all, not just nociceptors, it is also now all known to have myofibroblasts. It's contractile. So that's where this article kind of kicks in. I literally looked at all the different research over the years, and piece by piece by piece, it would retrospectively explain counterstrain piece by piece by piece. And around 2007, Dr. Jay Shah, who's on the paper, and again, he's another world-renowned researcher, keynote speaker, he came up to me for chronic pain in his feet, kind of a peripheral neuropathy, chronic pain. And he had, received acupuncture, needling, all kinds of things, injections, epidurals, nothing worked for him. And I applied this principle, and in the first couple of sessions made a lot of progress. And he said to me, how does this work? How does this, you're not really doing anything. You're just holding me. How does this work? And I said, well, I'm decreasing and draining inflammation out of these deep targeted tissues. And he said, there's no research to suggest that there's trapped inflammation in these deep tissues. I said, no, no one's ever tried to assess it. I said, trigger points, tender points, no one's ever looked. And he said, really? I said, check it out. So he went back and came back. And I said, you're right. No one's ever tested for that. I said, I'm telling you, we can feel it. You can just feel this stuff drain. It's how the whole technique works. So I went down there, and he had me speak to a bunch of world-renowned NIH researchers. I was like 28, 9 years old. Told them what I thought. They were like, you're right. No one's ever tested that theory. And then they developed a microdialysis needle, tiny little needle that could measure interstitial fluid. You guys, obviously lymph fluid, interstitial fluid. And went into active trigger points in a trapezius versus a trapezius with no trigger point, sampled the cytokines levels and even the catecholamines like norepinephrine in that tissue compared to the uninvolved side, and found there was an obvious elevation in at least 23 different pro-inflammatory cytokines, substance P, they're just, again, norepinephrine was all elevated. So it was the first objective sign of trigger points being anything that was, proven and why they could cause pain. And up until then, there were plenty of physicians that were still saying trigger points, tender points, they're psychosomatic, they don't really exist. The practitioner and the patient that both just made something up. So this was the first study that said, no, there's inflammation trapped inside of these active trigger points.
Vein Formula 1000 and Lymphatic Formula 1000 from Vita Support MD are backed by science and sold in doctors' offices. If you're a physician who may be interested in prescribing or selling these excellent nutraceuticals, please call 862-246-7877 to speak to a representative today.
So they now call that interstitial sampling studies, and it's been verified in ultrasound. It's all in the paper. But that was the proof that there was trapped inflammation, at least in this trigger point world. So anyway, that was one of the first key studies that had to exist to be able to explain how this entire thing works. But there were lots of missing links. And really until it got into the 2018, 2019, 2020, I still didn't see enough of these scientific breakthroughs to explain what we were doing. And then finally it got to the point where I kind of pulled the trigger. I said, okay, Jay, time to write this paper. And by the way, that study that he published and that, interstitial sampling microdialysis study made him world famous. So he owed me. So I was like, someday I'm going to call you back for a favor. So that's how I got him on board.
That's great. I'm gonna interrupt you there again, and I'm gonna pass it to Dr. Monica Gloviczki only because some of the things really caught my ear, and I wonder if we have any connection there. Dr. Gloviczki did a significant amount of her medical training in France, and you mentioned something about some French osteopathic physicians being kind of forerunners in this area. So, Monica, I would say to you, had you heard anything about this? And of course, Monica travels all over the world with her husband Peter at medical conferences, surgical vascular conferences, etc. And is this new to you? Were you aware of anything happening in France with the osteopathic community in this regard?
Well, certainly I had just personal contact with the somebody using the osteopathic treatment, and that was for my son, who was a preemie and had some difficulties in the beginning to actually to jump, and it was noticed by the school teacher, and she sent me to somebody who was supposed to solve it, and I know that I was, after a normal, very rational medical training, you have a hard time to believe what is happening, because that physician, osteopath, examined little boy and said, okay, so there was a issue certainly with his birth, with the during the delivery, that something maybe went a little bit not right. And literally, that was one session, and she was holding my boy head, applying, this pressure, and that's it. And that was one session. And well, after that, everything was fine. I couldn't, actually, he's perfectly healthy. And okay, he started to jump in one moment and moving perfectly normally. And I, to this day, I cannot tell you, did she, this osteopathic physician, did something, really marking valid for his development? Maybe. I was never 100% convinced, and it really, for somebody truly novice in that world, it looked strange.
This is a remarkable story.
My experience, which is really personal.
Well, it's a remarkable story, and I think it's very interesting that occurred in France. And now going back to you, Brian, is anything that Dr. Gloviczki and Monica is sharing with us in that experience, does it resonate with you? Does it make sense to you?
Sure. So a lot of your classically trained osteopaths, would do what they would call cranial sacral work, and much of that, lymphatic rhythm, cranial sacral rhythm, it was a very slow filling and closing, and they discussed it back in the day, saying it didn't match respiratory rate, it doesn't match, cardiac pulse rate. And so then people said, well, then it really can't exist. But the osteopath said it was more CSF and a lymphatic-based flow. And then lo and behold, as you guys I'm sure aware, in 2018, they realized that, guess what, the lymphatic system does go into the brain. So I always joke that the cranio-osteopaths went from, quacks to geniuses in 2018 because all this lymphatic, draining and ISF, CSF stuff, now we have this whole new world of the G lymphatic system to look into. But what I do is much more objective and based. It's much more anatomy based because back then, you could feel things. I always say the human hand, particularly those old osteopaths, would go into the direction that the body wanted to go. They could feel things. It was very difficult to scientifically explain what was happening, particularly if you're not working on something at the pulse, respiratory rate, or heart rate. How do you describe your fixing anatomy? At that point, didn't even exist. Okay. And so I hate to burst everybody's bubble out there, but the human hand has been way ahead of the science for many, many years. So now we're starting to say, what were we doing? And just because we couldn't explain it doesn't mean it didn't actually work. And so now it's time to start studying this stuff. But that has been the mission I've been on for 30 some years. Put the science to it, let's measure it. Actually, just Sunday, this past Sunday, I had, John and Jay, the two doctors on there, he came down from University of Guelph in Canada, John did. And I said, look, let's see what instrumentation can start to show even the musculoskeletal part of what we do. So I took a patient who I hadn't seen yet, who was a young lacrosse player with an S1 referred pain, sacral level 1, sciatic notch pain, low back pain, moderately chronic. I didn't want something super tough. So, I brought him in and I assessed him and came up with that diagnosis. Had John go down with a pressure algometer to his flexor flexor hallucis brevis, which is S1, S2. There was a big trigger point there on both sides. We measured it, went up and he did sensory testing and found that the S1 dermatome did have wind up. It was in fact, had some neuropathic pain. I went ahead and treated it and we remeasured everything right on the spot. And just for example, the pressure algometer on the S1 trigger point, and I treated it up in the spine, went from about 2.3 kilograms per square centimeter when he experienced pain, and it was 2.5 on the other side because there's one on both. Post-treatment, they both went to over 6 kilograms before pain was experienced, which is, anything over 4 is considered normal. So, again, completely shut it off. It was instantaneously measurable. Went to the S1 dermatome, all that sensitivity was gone. So the point is, in this more modern version where the anatomy is mapped out, we can research this stuff. We can research it objectively. It's not just, hey, I felt better, I don't know what they did, which is back where Monica was back in the day. Or we're not even sure it worked because we're not sure there was no control or no measurables. And so that's where we're headed. Is there any possibility that you could screen share? I can show you one little lymphatic before and after.
Yes, of course.
Yeah, even for your audience, because I've got something pulled up that I can show you just to show you a before and after severe lymphatic case, something in your guys' ballpark.
Yeah, Brian, I think you should be able to screen share. I think it's
all right. Let me see. Still disabled at the moment.
So many patients with Dercum's disease, Dercum's nodularity, which is the specific adiposity, multiple nodules, exquisitely painful to touch. And they can be at different areas. It can be in subcutaneous tissue, anywhere in the body. And this was not even documented yet. I found on the ultrasound in gluteal muscle is Dercum's nodules. When I do the ultrasound, it's clearly visible. Now, when I touch them, they are exquisitely painful. I will love to try your technique and see if that can be helpful.
Yeah, there aren't a lot of things that get thrown at me I've never heard of, but I've never heard of a Darcos nodule. So I'll have to get back to you on that one.
Maybe after we can get together and I'll tell you about the nodules and I'll show you what they look like on the ultrasound. It looks like a little snowball in a subcutaneous space.
I do treat adipose tissue. It's a subsystem, both subcutaneous, visceral, and even epidural. So it may be that area that I'm feeling, we have these adipose level areas of edema, and it might be what you're seeing. I just have not heard that term.
Okay. We'll connect and I'll show you the ultrasound.
Okay, yeah, that would be a great thing to do before and after. So let me, so here's let me shrink myself up here a little bit. Okay, so this is what in my lymphatic and venous class, I actually had in the foundations class. And what we have here is a lady who on Christmas Eve in 2010, she fell down and she had a small, humeral head fracture. And this was taken by her husband. This was the day before treatment. But anyway, so she fell down, fractured her, humeral neck, and was given a sling and swath. As you guys can see, she was discharged because it didn't need anything beyond that. You can see this right lymphatic watershed is severely edematous, and obviously lots of hemorrhaging taking place. So this photo is taken 9 days after she fell, and she was in chronic pain. And one of my teachers, Tim Hodges, he saw her this day, and she came in. He actually sent me this text and said, "Brian, would you treat her with your venous and lymphatic work?" I said, "Did she have a Doppler?" He said, "Yes, there were no clots." I said, "Absolutely, go ahead." So Tim started using. So this is 9 days in the presence of a lymphatic spasm, venous vasospasm, what the body could do, which was really nothing. She said she was in, 11 out of 10 pain, unquote. So Tim started applying the technique in the whole area, the subclavian vessels, all the way down into the, axillary, brachial, cubital fossa, did some artery and vein. It was, both sides showed up, did a little bit of general fascial work, and then got just past the elbow when he ran out of time. The next picture, is about 36 hours after this treatment. And again, this is 9 days before Counterstrain. And the next is 36 hours later, 2 days.
Wow.
Now, what's amazing, look where he stopped treatment. Yeah. Okay. So this is the radial and ulnar, all the vasospasm and some of the distal, vasospasm he did not get to. And I even said, Tim, looking at this, what's so interesting is how there was some distal drainage, yet it didn't really get through here. And he said, "Oh, I can explain that." And I said, "What?" He said, "The lady said, 'Hey, I feel so much better, but my wrist and hand still hurt.'" So he said he lathered her finger and her whole hand up in arnica gel, and then said, "I'll see you in a couple days." And so that somehow caused some drainage in the fingertips. But this was simply, this is what the body can do once this lymphangion vasospasm and the venous vasospasm has been removed, which is really another term for that is the sympathetic activation, which is a sympathetically driven vasospasm. But anyway, I wanted to just give you a little bit of context of what we're talking about here. And these things are not going to be all that hard to study because the changes are so fast. All right. But so in that case, there was, this vasospasm very likely in her right lymphatic watershed was probably pre-existing. And we all carry around a certain amount of dysfunction. That's why there's, some wellness work can be done. And then when she had the fracture, there was no place for this hemorrhage and edema to go. So I personally broken multiple bones and playing sports and things and never had that type of occlusion show up. So she clearly had some pre-existing stuff. Then that injury compounded it. So, what we have in reality, and one of the things I wanted to get into is that almost everyone in medicine, unfortunately, to be a specialist, to do research, you really get this really focused, narrow level of knowledge, this area of knowledge. So lymphatic researchers, they've got this massive, information narrow in the world of lymphatics. The pain guys have this massive, narrow, knowledge in the area of pain science. Practitioners become specialists. Like I'm a kidney guy, I'm a nephrologist. All I do is the kidney. But the problem is the body is not one organ. It's not one tissue. It's multi-system. It's peripheral. It's central. And it all adds up, to create the potential for dysfunction. So what this philosophy is a multi-system. You give all systems equal weight. We assess all tissues. We look at the central nervous system, the peripheral nervous system, and it's not easy to get there. It's a tremendous amount of training. But one of the things that drove this home with the article was while we were trying to get each little part hashed out into the level where we could get published, Dr. Sabelli, he's a neurologist. And he said to me one Zoom meeting on a Saturday, sitting right where I am now, he said, "You've done a really good job in the article so far of explaining the vasoconstriction, the potential for this trapped inflammation in the artery and vein world." He said, "But what is stopping this from draining out in the lymphatic system?" He said, you've got to be able to explain that. And I said to him, I said, well, it's got to be dysfunction of the lymphangion. And here we have two world-renowned pain researchers, keynote speakers on all these. And what they said to me was, "What's a lymphangion?" And I said, "The contractile unit of the lymphatic system." And they said, "The lymphatic system's contractile?" And their case in point. So So I pull up a video of the lymphangium pumping from my lymphatics class, and they're like, "That wow, that's fascinating. When did that come out?" I'm like, "Okay, it's been out a while." But that's when it hit me that the lymphatic people don't really get into the pain research, and the pain people don't get into the lymphatic research. So this article is really the bringing together of those two worlds, and it's just that tunnel vision, I think, that allowed this whole concept to go unnoticed so many years.
Very, very interesting. Jacqueline Sasek, any thoughts at this time? I know that you're so interested in the human body and the power of hands-on therapy and so forth. Any questions or comments?
Wow, I have a million questions, but where do I sign up for the treatment first off? Speaking for the patients right now, like where could they find treatments like this? How specialized is it?
Yeah, so on counterstrain.com, that's simple. Okay, so not strain, counterstrain, not fast, just counterstrain.com. That is an international website dedicated to the technique, the training of the technique, but there's educational, and you can do a search for a practitioner on counterstrain.com. There's links to the different countries I teach in, et cetera, but that is where you could get it. If a practitioner has taken 4 out of the current 12 classes, and it will be over 16 in the end because it goes all the way into the brain. If you've taken 4 classes, then you can get listed on there as a practitioner. You're not necessarily certified, but they're doing it as their primary modality. So someone who's taken just 1 class, 2 classes, they wouldn't be listed. Now, having said that, at our national convention, which is in about 2 weeks, people who are caught up, how many are there that are taking all 12 classes? Probably only about 300 nationwide. And some countries like France, we've got a whole lot of people in France because I've taught there for years and it's a small country. And then you can go to Australia where there might be 3 people at the point that are caught up in the whole country of Australia. So, it can be an issue getting to a top practitioner, and everybody who does it well has a pretty good size wait list, to be honest.
At VitaSupport MD, we believe in creating the best bioflavonoid-based supplements to support your vitality. Bioflavonoids are found in abundance in nature and support excellent health and wellness. The demands and stresses being put on our bodies in these challenging times are unlike any we have seen before. Support your body with the flavonoids it needs to fight inflammation and oxidation. Unlike other products in the marketplace, VitaSupport MD dietary supplements use micronized flavonoids for optimal absorption and effectiveness. Micronization is an advanced process which creates an ultra-fine powder easily absorbed by the body. At VitaSupport MD, we are passionate about making your good health our life's work.
And I have a question, because, with all this technique of actually what you want is to relax the tissue and get rid of all inflammatory cytokines that aggravate. Initial reaction makes sense, but in the chronic situation not. And I was thinking on this, the Tai Chi technique, which is based totally through the different movement into the relaxation of all your body. Is it that something that you think would have similar scientific maybe justification?
Yeah, I think, if you look at gentle stretching, where if you just stretch gently and you back off, there is some research to show that a gentle stretch backed off kind of temporarily speeds the lymphangium pump. So those gentle movements, coming out of them slowly, could stimulate lymphatic drainage. The real power of counterstrain is the precision, though, okay? Because we get into the exact structures and the right combinations where, like a patient I just saw today, the lady came in, and I'll just use an example from 2 hours ago. She had basically upper abdominal pain, GERD, and she had a full workup. She had endoscopy. She's had, everything done you can imagine, CT, MRI, thousands of dollars. She went to see a doctor who's like, okay, this is idiopathic, go see me. And so she came in, and when I assessed her, what I saw was that after talking to her as well, that she had chronic anxiety, and she had that since a kid. She had a lot of neck pain. And then when I went up, her area of dysfunction was in the medulla, and she had a sympathetic drive was elevated and all the way down. So the medulla coming out of the hypothalamus through the medulla is what's called the hypothalamic spinal tract, which is the pre-autonomic neurons to the preganglionic neurons. Then all your sympathetics fire. And what happens when sympathetic drive is high from that inflammation tract? Sympathetics drive heart rate, but shut down your gastrointestinal system, okay, because that shunts. So long-term sympathetic drive damages your parasympathetic system, shunts all the blood from your gut and overworks the heart. Oh, by the way, guess what she also had in her MRI? Cardiomegaly. So there's the sign of the heart being overworked since she was a kid, and her entire gastrointestinal system was shut down. So I didn't go and treat the gut because the assessment said this was sympathetic drive. So she had anxiety, cardiomegaly, and a messed up GI, constipation, gastritis, all sympathetic drive. Now, you could have the same symptoms from a local inflammation in the gut, like mesentery, but the point is the assessment says, where is this coming from? What is the source? And that's what we go through. It's multi-system. So a person comes in and says, I have chronic abdominal pain. There could be 50,000 different ways we would treat it depending on what the assessment shows.
So Brian, does this treatment help maybe too with like emotion regulation, since you can work on the nervous system? Yeah.
So we actually have a charity right now that is called the Bridge Back Project, and we treat 3 hours of counterstrain for free. It's paid by a charity for first responders and ex-military for PTSD. It's been funded by first responders and ex-military who went through it. They started donating to it to help their friends. We did do one so-called pilot study so far where we took 16 PTSD patients, did a CAPS-5 assessment on them, measured their PTSD, they all had PTSD, did 3 sessions, waited 1 month, 3 months, 5 months, retested independently. At 6 months post-treatment, 3 sessions, 15 out of the 16 tested negative for PTSD. And these are people, some of them are Gulf War guys, back that far. Yeah. So here's the thing is that, and again, we could talk for hours on any little part. I've talked to recently the Virginia Commonwealth University on the brain and sympathetic drive, and there's ways to apply this stuff. But the sympathetic nervous system, has a collecting vessels all around. There's pre-lymphatic channels all around it, and inflammation can get on that pathway, and then the threshold of that neuron drops because it's inflamed to where it fires all the time, or fires super easy. These ex-vets, these police officers, they just go off, so easy because they're already their threshold is just right there from firing. And then it can get to the point where these guys are just constantly like this. They can't sleep, they commit suicide, 18%. So it's a psychological trauma that causes a physiological problem because the fight or flight system drives the immune system and creates inflammation, cytokines. The one thing I want to say is, and I encourage anybody on the feed, any researcher, anybody, read the article, but I'm going to give you a real quick synopsis of how this happens. When you get a cytokine exposure in the body, and that could be from infection, could be from trauma, could be from hypoxia, could be from a pathology like RA, you produce peripheral cytokines, okay? And that could be from the immune system, like I said, from an infection or hit by a baseball bat. Then those cytokines, what happens is if they're in a high enough accumulation, this is the crux of the article, of course they cause pain, but they will then, specifically 3 of them, interleukin 1B, interleukin 6, and TNF alpha, those 3 stimulate fibroblasts to differentiate into myofibroblasts. And myofibroblasts secrete TGF beta 1. Well, in 2019, TGF beta 1 was shown to cause fascial contraction. So you get enough of those 3 cytokines in one area, you get fascial constriction, and it blocks pre-lymphatic drainage. So now you trap inflammation in that local tissue physically. Well, inflammation trapped, those same cytokines shuts down the lymphatic pump, stimulates nociceptors, which go back into the cord via the nociceptive loop, cause sympathetic activation, shuts down vasoconstriction, arteries and veins. So now you have no perfusion, no lymphatic pump, and you physically blocked it. And that little area of stasis, interstitial inflammatory stasis, and I called it inflammatory stasis because lymphedema would be interstitial, not inflammatory, okay? So now you have a positive feedback loop. And that can happen in pre-lymphatic channels around organs, vessels, nerves, and all the musculoskeletal tissues. So
actually, it let me think that maybe this is one of the aspect of the micronized purified flavonoid fraction efficacy in lymphedema, because indeed you have that anti-inflammatory action on the interstitial tissue, and maybe that unblocks the passage. Yes.
Look, if you look at the article, I've got a citation, and matter of fact, that was the smoking gun. The one head editor, he was a Chinese physiologist, and I couldn't say to him, he's like, how did you come up with the idea that this is all connected? And I can't say, well, I've done it for 30 years in the clinic. So I finally, in 2020, an article came out, and it showed exactly what I'm saying in secondary lymphedema. They examined secondary lymphedema, and they saw contracted and sclerotic pre-lymphatic channels, okay, initial lymphatics. And then the researcher said, we believe it's probably just, heredity and vascular cells that just hypertrophied, some kind of genetic thing. It was acquired lymphedema, though. And I'm like, no, it's myofibroblasts. And then I kept following that loop, and sure enough, somebody had studied right after that, tested the cells, and they were myofibroblasts blocking the flow. So this exact mechanism that I have for chronic pain has been shown to exist in acquired lymphedema.
And we also know, Monica, that the MPFF, the flavonoid, increases lymphangion contractility.
Yes, well. That's one point. But I was thinking that indeed, like in all this vicious circle that exists between the lymphatic circulation and inflammation at the local level, that certainly, it's that there is, I find some rational explanation in what you are describing.
Exactly. And again, talking about the physiology that we know of MPFF and this whole process of interstitial inflammation and edema and lymphedema, et cetera. We also have, with the MPFF, decreased capillary permeability. And that capillary permeability, we always have to keep in mind, which has come out in this program many times from our guests, is not just serum, it's plasma and containing proteins. And these proteins are pro-inflammatory in the interstitium also. And so again, as Brian is saying, and you're saying, it becomes this vicious cycle and feedback loop. And it's just a ongoing chronic pro-inflammatory state.
Yeah, and then look at our cases where you can start to look at this paradigm of vasoconstriction. Artery vein is a byproduct of it, but you got lymphangion shut down. You got trapped inflammation, causes chronic pain, any system. You've got regional segmental vasoconstriction. So like the football player who tears his meniscus in high school, he ends up setting up some of this IIS, interstitial inflammatory stasis around the knee and the meniscus. But the secondary effects of that trapped inflammation at the cord level is vasoconstriction. So now he has poor perfusion into his knee. 40 years later, he's got a degenerative knee on that same old bad knee side. So again, it's trophic changes, breakdown, degeneration is the vasoconstriction side effect over time. It's it eventually, through the autonomic loop part, doesn't feed the tissues. What's happening in the brain in CTE, post-concussion syndrome? If I get these people quickly, I can get rid of their brain fog, their headache, their eye sensitivity, great. But you sent me that guy who had the concussions in his 20s and he's 70. Well, now he's got CTE because that vasoconstriction, all that inflammation in the brain over time, lack of perfusion has damaged those neurons. It's called cell death. It's gone from the inflammatory stage into the demyelination stage into the degeneration stage. And I can restore the blood supply at that point. They make some progress, but I'm watering a dead plant. So the point is, if you start to look at this vasoconstriction, sympathetic nerve activation is what it's called in the pain science, it is the tissue breakdown that's idiopathic, okay? And why can you see it on both sides? Well, I had a lady this morning, also a new patient, bilateral hip replacements, very athletic, she's always done weight-bearing exercise, but I went up into her spinal cord at L1-2, those sympathetic neurons down to both hips were the problem. which has been causing vasoconstriction in both hips for many years, and they're both wore out, those specific two joints. Okay, so she's been exercising and running, and she doesn't have RA. Why didn't her knees wear out? Why didn't her ankles wear out? Why both hips? Because the hip level had the sympathetic drive.
Interesting. Emily, one of the things that Brian's brought to my front of mind also here is when you talk about the counterintuitive nature of this relaxation technique as compared to older, I like the terminology he used early on, this high velocity popping and cracking kind of approach that osteopaths, chiropractors, and so forth have used. I'm not going to judge it as positive, negative, good or bad, but that's a wonderful way of describing it, high velocity popping and cracking. We've all seen that and been, patients and treated and so forth. But it also brings to mind manual lymphatic drainage, how it seems to me when performed properly, and I'd like you to comment, is a very gentle technique. It's not a high pressure compression, squeezing, trying to mash fluid out of the limb. Can you comment on that, Emily?
That's true. Lymphatic massage is very, very gentle, but there are different levels. When you have already constriction and you have myofascial release and so on, and then we apply a little bit deeper pressure. But so now I'm just thinking a lot of lipedema patients, and lipedema is different than lymphedema. They have other issues. A lot of them have brain fog and fatigue or migraines and so on. And I would love to take your course so I can learn how to unblock everything, because the outcome is lipedema, but there must be much, much more to it than just enlargement of subcutaneous tissue. And I'm so happy that I managed to get here and listen to your fantastic lecture. And I want to go over and over because, and you had such a valid point when you said that the physicians are highly specialized and focusing only on their specialty. And we are not putting patients as one human being with all the different aspects of physiology, pathophysiology, and so on. So I want to thank you so much, because I learned enormous amount, and I would love to apply that to my patients with Derkum's disease, lipedema, lymphedema, and so on.
Yeah, so again, I guess there could be some people obviously that are lymphatic practitioners or others. I still practice simply because I'm still developing all the way into the CNS, and people who do this, we don't need more patients, we need more practitioners, okay? And when you start to have a multi-system paradigm and you can work on musculoskeletal and lymphatic and vasoconstriction arterial, and you can work on, CNS and brain fog and sleep disturbance, and, boy, who doesn't really need the work? That's the question. It's more that world. Then you just need practitioners. So to be honest, I go on these things because we need more of us. And we do have, the way to train is to go, and I'll give the website here. It's called JI for Jones Institute, Dr. Jones, JICounterstrain.com. Before I say counterstrain.com, there are links to it, but the Counterstrain is just educational. But JICounterstrain.com, that's the North American group that teaches it. And then you just want to go under curricula, you want to go to Fascial Counterstrain, because the old strain Counterstrain is still taught, but that's eventually not going to be around anymore. It's still taught a little bit, but go to Fascial Counterstrain, take the first class called Foundations. You'll go through the physiology. You learn 40 techniques in the first class. I didn't even talk about the assessments. There's 5 different assessments that we do that allow us to rapidly find out where the problem is. Okay, the source. And then you just start going, and then you can go to Lymphatics 1, Lymphatics 2, learn how to drain the lymphatic and venous system, all the extremities, the head, and all the way into the spinal cord, spinal veins, intrinsic and extrinsic veins of the vertebral column, epidural system, 2 classes. And what's different, though, than lymphatic work is, again, we'll go find that dysfunctional lymphangion, we'll fix that vasospasm so that it goes back to its normal pump. So we identify the problem, fix the kink, and then the body does its thing, just like that picture you saw. Let it go, let it do it. We don't force the fluid, we fix the restriction.
Fascinating stuff. Again, unfortunately, I think we're out of time today, but this has been an amazing discussion, mind expanding, mind opening. I'm sure our listeners, physicians and therapists and patients have all really gone on a journey with us today of exploration and greater awareness. And that's why we're here, Brian, is to, as you said, bring greater awareness, share what we know, and meet new people who can share with us so we can share with others, to bring to this world of healthcare many ideas and many points of view and many approaches and techniques and philosophies, because even myself as a cardiovascular surgeon, what you say resonates with me. In the days when I was doing open heart surgery, I was just thinking about coronary artery disease and sewing anastomoses. It wasn't a cardiac surgeon who came up with angioplasty and stenting. It was somebody else who was thinking a different way. And there was somebody else who was thinking about how to prevent atherosclerosis from forming at all with, let's say, lipid-lowering agents. So we're all kind of tunnel visioned in doing what I do now as a venous specialist. I can tell you I get referrals from arterial surgeons every single day who have the same board certification that I have, who say, John, you have to take care of this. I don't know anything about veins. So we do get tunnel vision, and there is a lot to know. And we do have colleagues like yourself in areas that, unfortunately, we don't necessarily interact with and collide with frequently enough to share with each other what we know, our experience, and hopefully continue to build a better and better treatment modality and care for our patients and ourselves and our family members and our communities and this world. So I want to thank you again for being with us. I'm sure we'll have you back. I'm already thinking it's one of our great dreams to have a hands-on workshop one day with the LymphCast crew and some of our friends and guests. And certainly you would be high on that list of invitees to come and participate and teach and share what you know. So thank you again for your time and your knowledge and wisdom. And Paul, why don't you take us out, if you would be so kind.
All right. Sounds good. We appreciate our viewers and our listeners. It's been a LymphCast episode 29. And we've already thanked Brian Tuckey. Thank you, Brian. Let's go around the table and thank everybody else. From Arizona, Dr. Monica Gloviczki. Thank you, Dr. Gloviczki, for everything tonight.
Thank you very much for having me. Thank you, our fantastic team. And thank you, Brian. It was really fascinating. And I discovered a lot of things, and maybe I will look with about my experience with my own son differently. Maybe she did something.
All right, very good. From New York, RVT, Jacqueline Sasek. Jacqueline, thank you for everything.
Thank you, Paul. Thank you, Brian. That was very informative. Thank you.
All right, from California, Dr. Emily Iker. Dr. Iker, thank you as well.
Thank you, Brian. And how can we reach you? Do you have email?
Yeah, so if any of you guys want to experience the work or need any questions about, you just email me. It's B Tuckey at tuckeypt.com.
Thank you.
If you go to
Tuckey.
Yes, Tuckey. And if anybody, if you go to any of those websites, you're going to find me because it's my stuff.
Okay.
Yeah,
it's great.
All right, very good. We also want to remind everybody, before we thank Dr. Chuback for everything, head to the website, lymphcastnetwork.com, and also send in your questions. The panel will handle those questions as they come in. And the email address for that is hello@lymphcastnetwork.com. And, of course, we want to thank the founder and owner of this show. He's also the founder and owner of VitaSupport MD. They make Vein Formula 1000, Lymphatic Formula 1000 from New Jersey, physician surgeon Dr. John A. Chuback. Dr. Chuback, once again, thank you for everything, sir.
Thank you. And Paul, thank you for reminding us about having our listeners email us with their questions or comments that they may have. And I want to take this opportunity to thank a lovely lady named Nancy, who called my office and sent an email. Nancy has listened to every single episode of the LymphCast podcast more than once. And as a result of our show, this is what's so fantastic. Not only is she taking Lymphatic Formula 1000 now, but she has been instrumental in sharing what she has learned here with her primary care physician. And her primary care physician apparently is very receptive to it and was not knowledgeable in the world of lymphedema and lipedema, et cetera. So Nancy, if you're listening today, and I certainly assume you will be, thank you for your note. We appreciate it. And from the bottom of my heart, and I speak for everybody, we thank you for listening, and please share the message with anybody that you think it may help.
That is very terrific news, and great work to everybody on the panel. And again, you've been listening to and or watching LymphCast. It's been episode 29. Have a great night. We'll see you next time for episode 30 of LymphCast. And that's it.
Wonderful.
Thanks, everybody.